Good afternoon and welcome to our Neuroscience Lecture Series. I am Dr. Galit Hakim, Vice President of International Healthcare Partnerships and Insurance Development at Baptist Health International. It is my distinct pleasure to welcome all of you to this informative presentation this afternoon. I would like to extend warm greetings to our friends across Latin America and the Caribbean and everyone joining us today. During this interactive presentation, you will have the ability to ask questions via the Q&A feature located in the bottom of your screen. I will be your moderator for today's lecture. This afternoon, I have the pleasure of introducing Dr. Robert Rothrock. His presentation is titled State-of-the-Art Care for Spinal Metastatic Diseases. Dr. Rothrock is the Director of Spinal Oncology at Baptist Health Miami Neuroscience Institute. As a spinal neurosurgeon, he specializes in the surgical and radiation-based treatment of spinal tumors in addition to complex spinal surgery. Dr. Rothrock received his undergraduate education at the University of Pennsylvania in Philadelphia. He completed his medical education at Albert Einstein College of Medicine in New York City, and then his residency in neuroscience at Mount Sinai School of Medicine in New York. He completed a fellowship in spinal oncology and radiosurgery at Memorial Sloan Kettering Cancer Center in New York City. Dr. Rothrock then completed a minimally invasive and reconstructive spine surgery fellowship at the University of Miami Miller School of Medicine. He subsequently joined Baptist Health Miami Neuroscience Institute in 2020. Dr. Rothrock has been the recipient of the Coleman D. Post-Resident Publication Award at Mount Sinai School of Medicine and at the 2019 Congress of Neurosurgical Surgeons. He led with the most accepted science abstracts. Prior to this, he was a recipient of the Doris Duke Clinical Research Fellow in the neurosurgery from 2012 to 2013. His research has been published in multiple peer-reviewed publications, including Neurosurgery, Journal of Neurosurgery, Spine Operative Neurosurgery, as well as other publications. He has also authored chapters in numerous medical and neurosurgical textbooks, and he's a member of the American Association of Neurological Surgeons and the Congress of Neurological Surgeons. Dr. Rothrock, it is such a pleasure to have you with us. Welcome, and thank you so much for this opportunity to hear you out.
Thank you so much. Very kind introduction, and welcome to everybody at a distance. I'm sorry we're not doing this in person, but one of the miracles of the modern age is the ability to connect so easily and effectively, even in an international circumstance. So thank you very much. And I really would love to hear some questions at the end of this, and I'd love it to be as interactive as possible. I'm going to go ahead and share my screen, which hopefully Dr. Hakim, if you could just confirm that you can see everything.
It's perfect.
Excellent. Okay. So I'm going to talk about a topic that no matter what area of medicine you're in, you're probably seeing at some point in your career and interacting with, and that is spinal metastatic disease. And let me just begin by saying I have no conflicts of interest or disclosures. Other than that, I love spine surgery, and that all the figures that I'm utilizing are according to fair use guidelines here in the US. So just speaking a little bit about the standard of care for spinal metastatic disease. So the whole idea of spinal oncology as a subspecialty is really relatively recent, even within the context of spine surgery. And we've been caring for patients with these diseases for a long time. But really in 2005, there was a critical trial published called the Patchell trial. And that was the first randomized clinical trial to basically show that patients with compressive spinal metastatic disease, if they had surgery plus radiation as opposed to just radiation alone, actually walked and functioned longer. And as a secondary outcome, had increased survival. So that was really the most convincing and earliest randomized controlled trial data that what I'm going to speak with you about today is in fact beneficial, right, and evidence-based. But the idea is that, and many of you, if you're surgeons or even oncologists or primary care doctors that maybe have seen patients benefit from these surgeries. So really, that should be the guiding principle behind all of this. If there's anything to hammer home today, it's that this works, and it really makes a huge difference for those of us engaged with treating this patient population. So let's just talk about standard of care. So over the last 2 decades, it's been shown that patients with cancer are living longer, right? We're doing a better job taking care of patients with cancer. We're helping them live longer with systemic therapies. And we've shown that at least some of that benefit has actually been conferred to patients undergoing hybrid therapy for spinal metastatic disease. So this figure on the right is a study we looked at Sloan Kettering, where we took over 2,000 patients who had undergone these surgeries and looked retrospectively. And rather than lumping them all together as a single cohort, we looked at them by year, and we looked at trends towards survival. And we actually demonstrated that over the study period, which spanned 20 years, each year, depending on the year of operation, those patients were living longer. And we know that surgery itself is not necessarily responsible for that. That's really probably coming from systemic therapies, so chemotherapy, right, checkpoint inhibitors, new age cancer treatments. But this is measured from the time of surgery, not from the time of diagnosis. So that's a substantial change when you think about it. And really, the point of all this is to say that these data really support the need for durable systemic and local treatment strategies. So in other words, gone are the days of patients necessarily dying a few months after these surgeries. We have patients now surviving 5 to 10 years after having surgery for spinal metastatic disease. So we really, when we think about all this, we now need to not think about here and now, but also later. So I use this term hybrid therapy. What is hybrid therapy? So hybrid therapy is the idea that surgery is only half of the treatment, because we can never cut out all of the cancer cells of the spine with these surgeries. But what we're doing with surgery is we're making radiation better, because we are separating tumor from either the spinal cord or the thecal sac of the lumbar spine, and we're allowing for the delivery of higher dose tumoricidal radiation therapy. So the idea then is that we don't need to do these highly morbid, extensive surgeries that last 10, 15 hours. We can do more focused, targeted surgeries that take 3 to 4 hours, and take enough tumor away from the spinal cord that we can effectively kill the rest with radiation. Now, inherently, that means this is a team sport. So there's a number of people involved. It's not just about me as a surgeon. This requires partnership between spine surgeons, radiation oncology, our PT and PM&R service, interventional radiology, medical oncology, really everyone, down to the techs and circulating nurses. Everyone is helping with this. And again, the goal is to provide durable tumor control, not just for a few months, but for years. And as part of that team sport, these decisions really shouldn't just be made by one surgeon, one doctor, one oncologist. They should be team-based and formal in a conference setting. But, there's a huge variety. When you talk about spinal metastatic disease, you're talking about any and every type of primary cancer, because the reality is the spine is the third most common site, or bones in general, third most common site of metastasis for any solid tumor. So when you think about that, it's a staggering figure. The majority of cancer patients, if they live long enough, will develop a spinal metastasis. So how do you juggle all these things? Is it based on surgeon preference, OR availability, or should it be on a rigid criteria? But at the same time, as I showed you at the beginning of this talk, everything changes constantly with cancer care. And the way we treat, for instance, renal cell carcinoma now versus 10 years ago is totally different. And so how do you adapt to those changes? So my mentor at Sloan Kettering, Mark Bilski, and Ilya Laufer, developed this idea of NOMS, or NOMS, depending on who pronounces it. But it's the idea of a framework that can help us think critically about who should have surgery, who shouldn't, with spinal metastatic disease. So there are 4 pillars in this system, and this is not an algorithm. It's not another thing to tack up on your wall and remember a score or a number. It's not a MELD score or an ASA criteria. This is an adaptable philosophy about how to think about this so that we can allow for changes and improvements in therapies. So there are 4 critical decision-making points in this framework. The first is neurologic. Obviously, I'm a neurosurgeon, so I care the most about this one. But that means both neurologic on clinical exam, but also neurologic as terms of the radiographs. So the assessment is both clinical and radiographic. So for the clinical portion, we ask, does the patient have myelopathy? Do they have radiculopathy? Do they have a neurological deficit or symptom attributable to spinal cord or thecal sac compression? And then the second half is radiographic. So now in the modern age, we use MRI scan, and specifically the T2 sequence, not the contrast enhanced sequence, but a T2 sequence to make this determination. And so Sloan Kettering made a validated scoring system to standardize how we all think and talk about this. And it basically, the salient question is there abutment versus is there compression and deformation of the spinal cord? So low-grade epidural disease is considered anything coming out of bone up until basically contorting the spinal cord. But once there is actual deformation of the spinal cord, we call that grade 2 or high-grade epidural disease. And the highest in the score is complete effacement of the cerebrospinal fluid. So here you can see there's still space around the back of the spinal cord, but here, right, there's nothing, just tumor. And unfortunately, we see this scenario a lot, and I'm going to show you some cases with this. But in this pillar, it's the patients that have this higher grade compression that need surgery. Okay, so lower grade disease we can often treat with still radiation or radiosurgery alone, but high grade disease is surgical. What about oncologic? What about the tumor histology? So the way we think about this is not based on necessarily the type of cancer, but how is that cancer best treated with radiation? So certain cancers are known to be very radiosensitive to conventional external beam radiation. So for instance, lymphoma, leukemia, myeloma, but also prostate and some forms of breast adenocarcinoma are very sensitive to conventional radiation. They don't require SBRT, as opposed to radio-resistant histologies, tumors that were always understood to not respond well to normal radiation, things especially like renal cell carcinoma, hepatocellular carcinoma, GI cancers, things that don't respond well, that don't melt away with radiation. So that's important too, because a patient that has a primary disease that's very radiosensitive, for instance, multiple myeloma, if they have no deficits or other issues, they may be treatable just with conventional radiation, even if they have a lot of epidural tumor. And it's important to spare patients that don't need radical surgeries, those surgeries. The third pillar is mechanical stability. So separate from is there spinal cord compression is the question, is the spine stable? And the way that we usually quantify that is with a validated score called the SINS criteria. So this is the only sort of other scoring system that you'll hear me talk about. This is a validated and standardized manner that, doctor to doctor, surgeon to surgeon, radiation oncologist to radiation oncologist, you can determine if a patient's spine is stable or not with regard to tumor. This was developed as a tool to help conversations between neurosurgery and radiation oncology, since often radiation oncologists would be seeing these patients without a surgeon present and having to make and sort of triage these decisions. But in general, the idea behind this is that as tumor invades bone, it weakens bone, and you can have fractures of bone that have nothing to do with compression of the spinal cord. But patients can have pain due to this mechanical instability. And until you stabilize it, either with cement or surgery of some sort, right, they'll keep having that pain, no matter how much radiation you give. So this is another consideration, because there is a subset of patients we operate on that don't have epidural tumoral compression, right? So this is not just a single sort of patient portrait. And then finally, systemic disease, right? So how sick is a patient, right? If we think a patient only has, let's say, 2 months to live, and the recovery from these surgeries is 3 months, why would we put a patient through that trauma? Because anything and everything that I do with regard to metastatic cancer is palliative. And that's not a bad word for me. You know, people are stigmatized about palliation, but palliation means relief of symptoms, right? It means focusing on symptoms, not cure. And that's very powerful for a surgeon because, you know, we really can be goal directed here. And there's no right or wrong answer with a lot of these surgeries. They're really tailored to the patient. Now, classically, the surgeon would sort of berate the oncologist and say, how long does the patient have left? And that's not a realistic conversation because none of us know that, right? Only God or nature, whatever you believe, knows survival. So my tool as a surgeon to ask and find that out is I ask the oncologist, what systemic options are left for this patient, right? So if the oncologist tells me, listen, we've gone through 9 lines of chemotherapy, immunotherapy, there's nothing left, it's probably not wise to put that patient through a surgery because it means that at the end of this, there's not another treatment, there's nothing left. Whereas if they say, hey, you know, if you can get this patient through this problem, then I've got this to try, this to try, this to try. And that's a very different conversation. So that's also this concept of metachronous versus synchronous disease. For instance, there's a difference between a 60-year-old woman who's been fighting breast cancer for 15 years, right, and gone through all these lines of chemo versus a 60-year-old patient who's never had any treatment, comes to the ER with a new metastasis and is found to have breast cancer. That patient's never had treatment and probably has a better prognosis overall because at least from measuring from the time that they're presenting to me, right? They're going to probably live longer. And we've seen that in our study cohorts and the study I showed you earlier, that patients with synchronous presentation, meaning they're presenting with a new diagnosis of cancer, but with metastatic cancer, they live longer from the time of surgery than patients that are getting a subsequent metastasis. So that's a lot to throw at you, and it's overwhelming because this is an overwhelming problem. But putting it all together, if we just think about this, who should have surgery? It's patients with spinal cord compression, with a disease that's resistant to radiation, and who from a systemic perspective can undergo surgery. They're well enough to undergo surgery per se. But also, you know, for patients that have mechanical instability pain, who may not have overt spinal cord compression, they sort of also, you know, qualify. So that's why this is important, because if you had a scoring system, it's hard to parse all these things out. But if you think about this deliberately, right, and I'm going to try to do that with you all in some cases, we can figure out who should have surgery. So with some of our remaining time, let's talk about that. So here's a patient. This woman is 73 years old. Okay, so she's older and she has known history of renal cell carcinoma. She's already had a surgical resection of a kidney, systemic treatment, and she comes in with trouble walking and back pain. And she gets an MRI scan and she's got pretty substantial burden of metastatic disease at what we call the thoracic apex. Why do we call it that? Because it's the most curved portion of the thoracic spine, right? If you look at this, you see the C shape. This is the most stressed portion. And for whatever reason, spinal metastatic disease has a predilection to go to this area. And we've demonstrated that this area has higher risk of progressive fracture and kyphosis, meaning bending over, than some of the other areas. And it makes sense because of the strain on this area of the spine. So not only does she have epidural disease and tumor coming out here at this level of T6, but basically she has spinal cord signal change. You can see there's a bruise in the spinal cord. And then also down at this level, thoracolumbar junction, right? So if you look at both these levels on axial view, you'll see the circumferential tumor higher up, right? Like I showed you earlier, grade 3 spinal disease, and then actually worse tumor lower, right? Look at this huge tumoral mass. So, using the NOMS criteria, right, we have high-grade spinal cord compression. We have a radio-resistant primary renal cell carcinoma. This patient also had mechanical type instability at this level, pain. And systemically, these are only 2 areas of disease. So, again, there may be a patient that says, listen, I don't want to do anything about this. I want to use my remaining time, however I see fit. But this woman, from my view, she still had multiple lines of therapy open to her, and she wanted to try, right? And so the question is, well, what do you do? Because these levels in the therapy, the standard surgical treatment strategy is usually to do 2 solid pedicles of fixation up and 2 levels down. And if you really look at that and think about it, right, those are going to adjoin and connect. And in a 73-year-old woman, to do a T2 to L2 fusion, in my view, is too much. So the question is, can we leverage technology and things we have to do smaller surgeries, right? So what we do first for renal cell carcinoma is incredibly vascular. So this gets back to what I was saying about a team-based approach. So for this, we can see this is a diagnostic angiogram. One of my colleagues in interventional neuroradiology did a spinal angiogram, and you can see how much blood supply there is to these tumors. They're incredibly vascular, and it's not uncommon, when you cut into this tumor, to lose a liter of blood in about 5 minutes if you haven't embolized it. So you can see, just to embolize this one tumor, right? Look at the amount of coils and glue, onyx glue, it takes, right, to embolize it. It's a big investment just by my colleagues, right? Then what do we do? Rather than doing this big giant surgery connecting these 2, we do 2 minimally invasive resections. And the way we do that here at Baptist is, at least in my hands, is we use cement augmented pedicle screws. So these are screws that have a hole in the middle where I can put bone cement into affected levels through the instrumentation. And then we reinforce the index level bone with something called a spine jack, which is a little titanium device to basically rebuild that level. So if you look over here on the left panel, that you can see the spine jack device in the bone here, and you can see it in the bone here. That helps me make this, stronger, and make these constructs stronger so they're more durable, and I don't have to do a giant instrumented fusion, right? And doing this with these 2 levels, embolizing and doing separation surgery, we can achieve really excellent decompression of the spine and realignment. You can see that it's better aligned, right? We've sort of brought her out of kyphosis even with this minimal surgery. And then at the lower level, you can see the level of separation we get. I mean, this effectively looks normal. And these are the cross-sectional views, the axial views, right, of our separation. So that lets us deliver stereotactic radiosurgery to this patient. And 6 months later, nothing, right? 100% tumoral response at both these levels, no epidural disease, durable. This is 6 months out. This patient is now almost a year out from surgery, right? 74-year-old, right? And she's still walking. And that's really the goal of this, right? Taking patients who others will be just maybe say you're not a candidate, right? Making them a candidate for surgery by doing less. Here's another example. This is a patient with metachronous breast cancer. So this is a 58-year-old who was told she was cured of breast cancer. Unfortunately, it's very common with breast cancer. We get patients all the time. This patient was 15 years out from treatment. She had had mastectomy, chemotherapy, radiation to her breast, had multiple PET CT scans, which I saw myself, completely free of disease, was living her life, and one day developed back pain, thought it was muscular. 3 months later, started having trouble walking, right? Now she's got the rest of the spine looks perfect, but 1 level of pathological fracture with massive amount of epidural disease. So just to show you that are not radiologists, this is the spinal cord, okay? The rest, all of this is tumor. So for this, what do? Same approach. We do 1 level up, 1 level down with cement augmented screws, place a device into the vertebral body to reinforce it, and cut out the other half of the vertebral body. And here, with a 3-hour surgery, we get circumferential spinal cord decompression. Here's the cross-sectional view. And again, 6 months later, after treatment with radiosurgery, durable separation, no other disease, right? Patient saw me, I'd say about a month ago, almost a year out now, and is disease-free. So this is the power of this way of thinking and this approach, in my view, right, is finally having long survivors with this problem. And just to show you, the scale of this, this is just 10 surgeries, all of whom are now about 6 to 8 months out. And just showing the power of this construct. Here's a patient that had a traditional separation surgery. So you can compare the size of this versus the size of this. We're doing it nowadays smaller and better, and leveraging this sort of approach and technology. The corollary, the opposite of all this, is primary spinal tumor. So this is a case of a 58-year-old gentleman who had just axial back pain and had this huge erosive tumor affecting 2 levels of the spine. This patient has no cancer history, has this fluffy tumor that's mildly and heterogeneously contrast enhancing with compression of the cord. So when I see this with no diagnosis of cancer, and this patient did not have a biopsy but was getting weak, I'm thinking this is a primary spinal tumor. So your approach for a primary spinal tumor is different, because here, you have a possibility at a meaningful resection and possibly curative operation. So this patient was treated with a 2-level corpectomy, or what we call a vertebral column resection, where we embolize the tumor beforehand, and then we remove those completely, the 2 levels of the spine affected. We use a similar approach with basically cement augmented screws and dual rods here for added support. And this is a cage, titanium cage, in place, and you can see the size of this patient, no small task. And this was a chordoma, which is a primary tumor of the spine that behaves like sarcoma. So a different approach. This is what I would say one to be maximally invasive as opposed to minimally invasive, because these patients with good, even intralesional resection versus en bloc resection can live, 15, 20 years without issue. So just very briefly with the remaining minutes here, what type of radiation? I was talking about radiation after surgery. So like I said, that depends on the tumor histology. For entities that are radiosensitive, we use conventional external beam radiation. That's usually 30 gray and 10 fractions. That's the standard sort of external beam radiation used for the spine. But for stereotactic radiosurgery, at Sloan Kettering, we very commonly use 24 gray in 1 treatment session. Here at Baptist, we tend to use a hypofractionated radiosurgery, and that can be anything from 24 gray in 2 or 3 fractions to 40 gray in 5. We have a few different protocols based on my colleagues' preferences and our clinical trials we're running. But really, the important thing to understand here is that for a patient, a fraction is a session. So, SBRT stereotactic body radiation therapy lets us do less sessions of treatment, higher dose, more tumoricidal. The other benefit of SBRT as a strategy is we can spare the skin. So if we do a big surgical incision, we can spare that during the wound healing. And so I can do it earlier after surgery and thus prevent tumor from recurring or progressing quickly. Conventional tends to, with lack of better terms, it fries the skin. So we want these incisions to heal. And so the radiation treatment sometimes is impacted by that. So one of the benefits of these more minimally invasive approaches is we can get the patient sooner, even to conventional radiation therapy, because they have less incision to heal. Just to show you the level of complexity with SBRT, it takes a lot more planning. It's a much more involved procedure, and it involves radiation oncology and neurosurgery because we have to map out all of the organs at risk, including the spinal cord, as well as where we think the tumor is. So what are the outcomes of all this? It's nice that Rothrock's claiming, it's wonderful. Every surgeon loves to claim their quote experience, but what's the data? So when Sloan looked at this in one of the earlier cohorts, they looked at 186 consecutive patients. They weren't cherry picking. And even in that early series, the local control rate was 84%, which is remarkably high, meaning of patients that survived 1 year or more, the cumulative incidence of recurrent disease at that level of treated disease was only 16%. And furthermore, with patients getting hypofractionated radiation only, so looking at the patients getting SBRT, that was even better. It's like 90% local control at 1 year. And what was super interesting about this study is that it wasn't associated with radio-resistant tumors. So in other words, radiosurgery is very effective at treating histologies that 20 years ago progressed and got worse no matter what you did, right? So it's really sort of a game-changing treatment paradigm when you think about it that way. And furthermore, looking at patient-reported outcomes with standardized scales, these surgeries help patients when they're indicated. If they have pain, we improve that pain. And that's been shown in numerous studies, whether it's Sloan Kettering, MD Anderson, AO Spine Knowledge Foundation. These are treatment paradigms which really are pervasive in most large cancer centers now. This is sort of the standard approach, not necessarily NOMS, but definitely the combination of radiosurgery with separation surgery. So this really is standard of care in my view at this point, and anything else is falling short. I just want to, before we take some questions, I'm really truly approachable, and I'm happy to take any questions, whether now or through the international office, however you want to reach me. I personally, I ask my mentors all the time about cases, and as we all know, no care should be in a vacuum. We should all be able to discuss interesting and difficult cases. And I also recognize that some of the things I'm talking about are I'm in a high resource setting. I have a lot at my disposal, and that's not true for everyone. So what I would tell any spine surgeons listening who are dealing with this, something I may treat with radiation, you may treat with separation surgery. You may need that for the benefit of the patient if you can't get them to radiation quickly. So not any of this is a panacea. You do what you think is best for the patient and is supported by evidence. I really want to thank everyone for letting me talk about this. As you can tell, it's something I care about, and really serving this patient population who often are dismissed and sidelined. And I would really welcome any questions.
Thank you so very much, Dr. Rothrock. We're really fortunate to have you in our organization. Your expertise are absolutely outstanding. Some of the takeaways that you shared with us, especially at the beginning, is the fact that obviously the approach is a hybrid therapy for metastatic diseases. And surgery is really half of the treatment, which is a complete shift and change from the old days of actually dealing with spinal tumors, allowing radiation to really play a role in the survival of the patient and not just use it as a palliative treatment alone. That is quite remarkable. In your opinion, what it is that it's more exciting about your areas of expertise nowadays, using this technology, meaning using radiotherapy in combination with your surgical approaches? What are you most excited about? What do you see in the future that the environment is going to serve the purpose of actually perhaps curing completely the patient, but at least alleviating and extending the quality of life for that patient?
Yeah, I think that's a great question, Dr. Hakim. And I think that, it's going to sound weird, but I think shrinking the surgical portion of this is sort of the what's exciting. It's pretty rare that surgeons get excited about taking business away from themselves or whatever, that conflict may be. But, I think more and more we're finding uses for radiosurgery. And I'll tell you a few things. One is at Sloan Kettering, we started looking at doing radiosurgery for lower grade epidural disease. So meaning I showed you grade 2 epidural disease. We had a cohort of about 35 patients that we treated with that approach, just radiosurgery, even though technically everything we were saying, right, was to do surgery for them. And those were patients mostly that were on the sicker end of things. Maybe they were further along their cancer journey. And ultimately, it was better for them to have radiosurgery, right, without cutting the skin. And the results were very positive in that. I mean, it's retrospective, not randomized, but, local control rate was still around 86%. And that, when you think about it, it's amazing, right? And most of the failures in that study, there were, the patients that progressed were those patients at the thoracic apex, that area that I showed you, because there's a lot of physiologic strain. So, I take that regional area very seriously. So that's one aspect, right? Is finding patients within the surgical population who actually, could we do something smaller? The other part of that is, things like the spine jack device or vertebral body augmentation, like I showed. There are some situations where if we can restore height adequately, or treat with smaller procedures instability pain, right, we can push it even further. Because then you don't even have to interrupt chemotherapy or radiation. Those are things with such small incisions that basically you can keep treating without interrupting. And ultimately, cancer patients, it's really important. Everything you do has an effect. So that's one part of it in terms of exciting things. And one of the other things we're looking at, I was talking today with one of my colleagues, is, we're planning a clinical trial to start looking at earlier radiosurgery. So it turns out in the literature, from the time most of these lesions are discovered to when they are treated or become operative is about 4 months. And like you alluded to, traditionally, this has all been about palliation. It's all been about symptoms. So in other words, the time from when you discover a spinal metastasis from when it starts hurting is about 4 months. So what if you do radiosurgery for those primaries before a patient's symptomatic or mildly symptomatic? Does that stop the progression to this higher grade epidural disease? We're scanning patients now much more in cancer centers, getting PET scans at regular intervals or MRI scans, and we find these things earlier. So one of the big questions is, are we doing it wrong? Because we have a study coming out in the next few months in the journal Neurosurgery, where we looked at this question: once patients are in pain, when we do a surgery, do we actually restore them to no pain? And the answer was no. Once a patient's in severe pain, we'll help it, but not back to nothing. Whereas if you intervene earlier, those patients could return to a painless state. And so that this whole idea of earlier intervention, right? We all know logically early intervention for most things with cancer is good. And maybe this is too. So that's sort of the exciting way this is going. The technology is also getting better and better. So I'm doing things with navigation, GPS for instrumentation, where I can do things through smaller and smaller incisions. I don't need a big spinal exposure. And that's amazing too, because again, less cutting is better for these patients. They don't heal well. They have compromised mobility. They have compromised nutrition. The less is more,
Definitely. And you did mention, the fact of the matter is that we are fortunate to be in the environment that you are, simply because you have in your armamentarium the tools necessary to treat whichever level of disease progression that you have. In your opinion, what would be the most logical approach for those countries that do not necessarily have these type of advancements in technology, but we still deal with the spine neurological conditions as traditionally they have.
Right.
What would you recommend they do in regards to that aspect?
Yeah, it's a good question. As I was alluding to, and this is my view, I don't think that means you don't operate on patients. I've had the pleasure of knowing many surgeons all over the world, and you're right. Settings are different. But most places have access now to spinal instrumentation. And if there's anything I would reinforce, it's that the days of doing laminectomies alone or just spinal decompression, it really shouldn't be done. I mean, there's overwhelming evidence that you need to instrument these patients. And the reason is that their tumor is eroding all the stabilizing measures. And especially in the thoracic apex and the thoracic spine, the spinal cord is draped right behind the spine. So if you fall forward, you get a ventral spinal cord injury, and that's that. So if you take the tension band, if you do a non-instrumental laminectomy in thoracic spine, you're risking that. And if you have access to instrumentation, it should be placed. But part of that is you don't need, look, I'm using cement, I'm using this device, but you could, and there's good evidence for these shorter segment constructs. So you don't need to do, and I could show endless x-rays of mine with massive spine constructs for infection, for tumor, right? But ultimately you just need fixation above and below. So if you're in a lower resource setting, do one up, one down. I mean, not for the cervical spine, but for thoracic, lumbar, it's usually sufficient. And if you can't get a patient to radiation, then do more tumor resection, or be more aggressive. That's my feeling, because just because you're in a low resource setting doesn't mean you should be paralyzed.
Right.
And even if you make room for the spinal cord, you'll still extend that ability, I think, but there's no perfect answer. And then finally, even if you have conventional radiation, the Patchel trial was done with conventional radiation. So even if it's conventional, you still have a benefit to surgery plus radiation. You don't need all the, it'd be better to have stereotactic available, but if you don't, at least surgery plus radiation, is beneficial.
Does proton therapy play any good roles in the treatment of spine tumors?
Good question. Absolutely it does, but it depends on the histology. So we use at our institution proton more for things in the sarcoma range, and pediatrics, we use it more. I think someone had a question about pediatrics, but it's rare, thank goodness, that we have metastatic renal cell carcinoma in a pediatric patient, but we do see hematological malignancies and things like chordoma and neuroblastoma, right? That's the realm of proton and higher delivery radiation doses, is really sarcoma and soft tissue cancers. So, but we don't use it a ton in separation surgery because most of the tumor histologies respond to radiosurgery. We that patient I showed with chordoma got protons, and again, we are lucky that we have a proton center and we can use it where it's appropriate, but it's not perfect either. And protons, although they don't travel past point, they do travel through skin. So protons actually can result with spinal issue, you can get burns and secondary effects. So, whereas with SBRT, we can adjust the arcs and really sort of hone in on all this, so there's no easy answer, but yeah, and there's also carbon ions and all these other tech that are coming up, but the mainstay is still gamma radiation.
Yeah. And at this stage, when the patient is already in the last stages of the disease and it's progressing rapidly, there's always obviously a question about complication, especially from a family member. You have to Is this really a
course.
beneficial kind of a treatment for you? And what would the complications be? And if there are complications, how severe in comparison to your condition is? So, and that is what Ruth is probably alluding to. What are
That's
some of the
right.
complications that you have encountered when dealing with this type of cases?
Got it. Yeah, definitely. It's a real question, and ultimately, every surgery, everything in life is about risks, benefits, and alternatives. So, in general, I always tell patients, unless I think there's a 70% chance or greater that you're going to get better or this is going to be effective, we shouldn't do it. Should not be a coin toss. And if it is, even more so, like you're alluding to, we should be conservative. So if there's more of a question, don't do it, because the last thing we want to do is cause harm. The last thing we want to do is lead to a patient spending the remaining days recovering from a surgery. It's just not, in my view, it's part of my job to not present a menu to a patient. Okay, so there is a tendency I've seen with physicians, that they say, well, here's option A, here's option B, what do you want to do? And, for some people, that's an effective way to do it, but that's not why people come, in my opinion, to a doctor. You know, you can present those options, but you should present your opinion on what you think should be done. And I say to patients, look, I'm willing to be aggressive, right, and do this, but I don't think you're going to do well. And if you move forward, you need to know and understand that. And the implication in saying that way, right, is I don't think you should do it, right? But
Right.
still, I'm not a fascist, and you offer, right? But sometimes I say to patients that are, scared of surgery, but they have a lot to gain. Look, this is scary. Here are the complications, and I'll describe a few of them, right? Mainly the complications, right? You're operating on the spinal cord, so you can cause spinal cord injury. I had a patient early on that had a T11 massive met, and I was trying to put in a corpectomy cage, and I, hit the spinal cord trying to put it in. And that's a risk of surgery, right? No surgeon, we all have complications. You can bet that I say that before surgery, right? But you hope it never happens to you. Luckily the patient recovered from that, but that's part of why I started going smaller, my surgeries, because I asked myself, well, why was I doing a corpectomy? Is there something else I could use to give me the strength of that construct without doing it that way? And the spinal instrumentation companies don't like that, because the corpectomy cage is quite profitable here, right? But is not best for the patient, right? So that's part of why I went smaller. But yeah, spinal cord injury is real. Leakage of spinal fluid. So when we are operating on the spinal either cord, or we're operating on the thecal sac and the lumbar spine, right? We're not actually looking at the spinal cord. We're looking at the dura, the lining, and that lining can be very stuck. It's very rarely stuck unless patients have had prior radiation, but sometimes they have, and you get a leakage of that fluid, and that is a connection to the brain and the spinal cord. You can get meningitis, arachnoiditis, nerve scarring, tethering, right? There's all these bad things. But usually we are able to repair that at surgery, and it's not an issue. But wound healing, I'd say, really for these patients, wound complications are the thing that I think sets them back the most. And it's not necessarily infection. If I go back to my talk, you'll see that the renal cell patient had seroma cavities, basically fluid cavities, where there used to be muscle, right? Things, whether it's from surgery or radiation, we always argue whose fault it is, but it's both. And the tension of that fluid over time, just like a blister on your finger, will wear down and sometimes pop. And even that, right, is another surgery to fix that. And so, I leave drains for a pretty long time in these patients. I don't rush them out of the hospital. And that's to try to get that all to scar down, but it's not perfect. And that's an additional surgery. That's not much palliative about having multiple surgeries, right? So, we're more aggressive. We give a lot of antibiotics. We use drains. We sometimes have the plastic surgeon close the patient, to do everything you can to mitigate these risks. But ultimately that creates higher cost surgeries for, like you alluded to, patients that may not live that long. So there's nothing easy about it. And again, I think that's part of why smaller is often better, and smarter is often better. I think that if you think a little more, or you challenge yourself and are a little better strategically, you can get around a lot of this.
And to underscore, in 90% of local control after 1 year, that is something to actually ponder upon.
Yeah.
Something to take into consideration.
Right. But at the same time, right, you're not extending necessarily life expectancy with this, but it's about quality of life. This is all about walking and using your arms and legs and having meaningful function as you fight cancer.
Absolutely. Two more questions before we let you go.
Sure.
What is the length of radiation treatment post-surgery typically?
Yeah, so it depends is the answer. So if it's conventional external beam, that's 10 sessions of 3 gray, total dose of 30 gray. And that I don't start that until at least 2.5 weeks after surgery, or at least until the skin is totally healed. Sometimes we have to be faster because, for instance, myeloma can be very aggressive depending on the case, and it can recur within a week of surgery. And you may not know that it's myeloma when you do surgery. So it's helpful to send, if you don't have a tissue diagnosis, you got to send frozen section, in my opinion, during the surgery, so the pathologist can sort of hint at what they think it is. But, the soonest I've ever started is within a week of surgery in a case, that needed radiation. And then it depends on the session, but radiation is almost always done consecutively. Mm-hmm. So those are 10 consecutive days, sometimes pausing for a weekend day. But 10 consecutive days of conventional, or 1 to 5 sessions of stereotactic radiosurgery. So it's done pretty quickly. You're talking about from surgery to end of therapy within a month, usually. Something like that. And then usually at 3 months, we'll get a follow-up MRI scan or PET scan, depending on the circumstance.
Mm-hmm.
Yeah.
All right, 2 more questions here. And what is the recovery time frame after the case of maximal invasive under normal circumstance? Will physical therapy be used post-operatively?
Yeah. So good questions too. So, physical therapy is an interesting thing, at least in America. The common wisdom for most people is that you exercise away problems. And that's not how I think about it. I'm putting in these constructs that are delicate. They need to heal. In the case of elective fusions, the bone needs to fuse. The reality is, although we call these fusion surgeries, very few of these patients fuse the bone together. And that's part of why I use cement and things to strengthen the screws. Because after about a year, if you haven't fused, screws tend to loosen if you haven't done something else to reinforce them. But, in general, the recovery is 12 weeks, regardless of what the surgery is. That's sort of my standard. And that's not evidence-based. That comes from observation, that most patients will, feel better after 3 months, regardless of the type of spine surgery. I find that a lot of these surgeries, especially if patients weren't walking, now they're walking, right? That people, it's not like you lie in bed for 3 months. We mobilize our patients early. My thing is out of bed to chair. I don't need them to walk, but I want them in a chair the first day after. And they're usually hospitalized for this type of surgery 5 to 7 days. If they're doing great, they go home. If they weren't walking, they may need to go to inpatient rehab. But true physical therapy, in the sense that the question is probably originating from, we don't start until 3 months after surgery. Because I don't want to strain the hardware. And the reality is that it's tincture of time is what helps patients. Physical therapy is something active patients can do to participate in their recovery. But the truth is, what it does is keep the muscles conditioned while the spinal cord recovers. It's not somehow mystically healing the spinal cord. So that's what I would say, and that's my opinion. It's not an evidence-based statement, but that's what I do, again, to facilitate healing.
And we will take that, since you are the expert in this field. We're going to let you go, Dr. Rothrock.
Oh, no problem. If anybody, wants to email or reach out, I'm truly happy. If there's any case We're here, and it's not just me. The other thing I should say is that, I have wonderful partners at M&I and MCI, and there's just really nothing, thank God, we're not handling now, and really nothing we need to quote send out. I came to bring the level of care and surgery I was doing in New York back to Miami, and that's really why I'm here.
And again, we're very fortunate, and indeed, we know that you have phenomenal partners at M&I, and especially at MCI. In any event, on behalf of Baptist Health International, I would like to thank you, Dr. Rothrock, for your informative presentation today, and to all of you for attending and participating. If you have additional questions today about today's presentation, please feel free to email them to us at bhiwebinars@baptisthealth.net. That is bhiwebinars@baptisthealth.net. We look forward to seeing you at our next neurosurgical lecture series, tentatively scheduled for October 19th, 2022. Continue enjoying your summer. Stay safe. Thank you so very much for your participation.
Thank you. Thanks to all. Take
Thank
care.
you.